you so much for the invitation and really appreciate putting together such an excellent webinar. And really appreciate also the overview of how artificial intelligence is changing surgery. I'm actually a radiation oncologist, but I spent a lot of my career, I was actually helped co-direct the program at Hopkins on radioembolization, and then was hung out a lot with surgeons. I was involved with starting the intraoperative radiation therapy program at Hopkins, so got to spend a lot of time. And I think to your point, I think we're still defining exactly what how exactly this is going to land in terms of different technologies and such. But we still, I think what's exciting is we're just getting started. We've made a lot of progress, as I'll outline. But really enjoy partnering with surgeons as we further develop this, and with Koji and Albert already really have enjoyed, and just giving credit, it's innovators like Koji and Albert that have really helped us evolve the technology in a very short period of time. So without further ado, I'll jump into the technology, and then we'll hand it off for some cases. So I'm going to go ahead and share my screen here. No, I think what's really cool is I've been a big advocate of multidisciplinary care in general. I think by we have so much, each of us brings something different to the table. And again, this technology is very unique in that I think it really is the first technology that spans disciplines, where it can be used by different groups, et cetera. And I think, again, that's going to help us get there faster. So let me go ahead and can you see my screen?
Yep.
Okay, awesome. And there's I won't read through this either, but there's our disclosure. So, I think as we break it down, again, as mentioned, this is really, it really is an automated sonic beam therapy. So I think it does fit into the category 5. And thank you for the overview. I learned a lot. And so as we think about, where this is going and where it can be, I think we're right now, as we're going to talk through, the actual targeting is still done manually by the physician using what we call our space mouse, which I'll show you. But ultimately, then once it has been determined, it does automatically drive the histotripsy through the treatment zone that the physician delineates. Just to walk you through, everyone here, what exactly is the technology? Again, it's the company is HistoSonics. The technology is called Histotripsy, and the device is called Edison. And Edison here, you could see, it does have wheels. It's really important to delineate that it can be plugged into a regular outlet, does not require a shielded OR. It can be in different rooms throughout the hospital. And it's relatively simple. You can see that within the box here is where we have the generator. The generator is which creates very high voltage that flows up through the robotic arm into what we call the transducer. Inside the transducer, we have these piezoelectric elements that are activated and generate very high ultrasound beams. Those beams coalesce into, basically similar to radiation, a single isocenter, which is where it creates a very high pressure that activates water vapors inside of the tumor cells that expand them, create these bubbles. And as those bubbles expand and contract, it then shears tumor cells, immediately lysing them and creating an acellular lysate. But what's unique is that it's not through apoptosis or other mechanisms. It's through ferroptosis and necroptosis. So it really does preserve a lot of those antigens and proteins that can then potentially be also recognized by the body. And then you can see here, the patient obviously lays on the table. There are no incisions. This is what we call the coupler. And it has a very patented membrane that sits on the patient's abdomen. And then we put degassed water in that, through which then the treatment head is entered in, and you'll see that here in just a minute. The actual Edison comes with an entire suite. So in addition to what I just mentioned, there's also a GE device that connects in through the transducer, and you can't see it well right here, but there is a ultrasound probe that can be retracted and so it can be up against the patient's body to give you optimal visualization. And then this here is the touch screen. This is really, again, for radiation oncology, an example of that. This is really everything you need. This is record and verify. This is your treatment planning, everything built into one. And this allows you to do DICOM, deformable registration, that allows you to drive through the patient's body with that integration and visualization. I won't show the whole video, but I'll just show kind of a part of it, and let me know if it works. I know sometimes these things don't work. Can you see the video right now? Okay, cool. In that case, I'll back up just a tiny bit here. So again, you could see that the transducer goes over the patient's body. You could see the coupler that's placed, and you could see, again, non-invasively, the ultrasound beams going through, and then you can see it coalescing to a specific place. Koji and Albert can get into this a little bit more, but you could see this is really the most important thing with histotripsy is the targeting, and to make sure that the tumor is definitely encapsulated within the volume that the physician delineates. And then once that volume has been delineated, literally, you can see here, that's the automatic treatment where the robotic arm is automatically moving the bubble cloud through the volume that the physician delineates and instantly destroying that tumor. And I think that's a very important differentiator between histotripsy and other liver-directed therapies in that we get that immediate effect. It's not a delayed effect. And here's just a nice little cartoon that delineates exactly how it works and how it moves through. Now, right now, the dose of histotripsy is set based on the FDA and based on our indication, but this is just the beginning. Similar to radiation therapy, we have the capacity to create bigger bubble clouds, smaller bubble clouds. We can create what's called a saber that allows, potentially to do surgery without any incisions, et cetera, as mentioned. Again, just to kind of delineate how precise this technology is, you could see this is a blown up version of the bubble cloud. You could see these bubbles just rapidly expanding and contracting. And what's really important is this is really the only place that the destruction occurs. Unlike proton therapy, where you still have entry dose, or microwave, where you're going to have penumbra that's outside of that region, the physician can feel very confident that wherever they put that volume, as long as they stay within that volume, that's what's going to get destroyed and essentially no effect outside of that volume. So it really gives you that comfort in knowing that if you're right up against bowel, for example, that you're covered. And then this is just showing you that this is how we interrogate. So this is a bovine tissue inside an agarose gel, but it's really to just help show you that we're able to make sure that you can achieve enough voltage to create a histotripsy bubble cloud throughout that entire volume. And then that interpolates that data to then make sure that there's enough voltage to create a bubble cloud through the entire volume that the physician delineates. And this is obviously sped up, as you could see, but it just shows you again that even within a soft agarose gel, how precise the technology is. And then you could see that once you cut into it, that again, you get this acellular lysate, but also just notice how precise in the fact that there's really no damage to that surrounding agarose gel. A lot of times folks will bring up, well, isn't this just HIFU? It's just another version of HIFU. And to be honest, there's a lot of claims of histotripsy out there, but this really is not HIFU. It's actually quite the opposite. It's really, instead of low amplitude and where you're really using thermal ablation as a way to destroy the tumor, this is the opposite. It's high amplitude, high pressure. It's very short microsecond pulses that, again, only affect, it's an all or nothing response. It's either on or it's off. There's literally no effect leading up to that point effector, and it's mechanical destruction causing that cavitation. And here's just an example. This is from our Hope for Liver study that I'll talk about briefly, but you could see the volume again that the physician would delineate. Once that volume is set, it's treated automatically. And here's just the thing that as a radiation oncologist, I spent 25 years guessing where the radiation beam is. I think this is just a video to show you, it gives you that confidence that you could see exactly where you're treating. And that, again, that way you know that you want to make sure that bubble cloud, for example, if you're right up against bowel or stomach, that you want to stay away from that. And then, this is on MR. You can see really the treatment zone that has been created. And I'll be very transparent and say it doesn't always look, in these guys, I get no Koji and Albert will say it doesn't always look this clean, depending on the tumor, depending on, if the liver is cirrhotic, et cetera. But again, you can have confidence that wherever you treat, again, the only area that is treated is in that volume. And then just to kind of highlight this more, you could see even at a microscopic level, what you see centrally is the acellular lysate that the histotripsy creates. And then just adjacent to that, you see hepatocytes. So really literally no penumbra outside of what you treat. And then another very unique aspect of histotripsy is that we can treat centrally. We can treat across vessels. We could treat across ducts. And that's because, again, the dose of histotripsy is set at a level that does not destroy structures that are more tensile, again, such as ducts and vessels. It does destroy the tumor cells inside and outside of them. It does destruct some of the intimal layers of those vessels, but they do regenerate. In over 1,500 patients, we've only had one bleed to date, and this is even after treating many patients who have had other procedures leading up to it. The other unique aspect of this is that you get involution after treatment. So you could see the treatment zone after treatment here. And then as you follow this patient, you get regeneration of the liver parenchyma around that area. And really, you're just left with a small defect after it's all said and done. So again, this also allows you to not really damage liver or real estate, leaving opportunities down the road. Right now, we tend to treat a lot more late stage patients. But again, you can see the opportunity for younger patients or where you're trying to save salvage treatments later. And I think, as mentioned, ultimately, I think surgery in a lot of cases will lead to being the salvage option, as this could lead to being more of an upfront option for patients. So in summary, it's completely non-invasive, single therapy, unlike radiation, where you tend to have to do 5 or even 30 treatments. No radiation-related toxicities. It is automated as described. You can do multiple treatments. In some cases, 10 different tumors have been treated in one setting. And then it's a mechanical process, again, that alters the tumor microenvironment. So, it's not part of our indication, but there's definitely excitement about doing research to better understand how the tumor microenvironment can maybe be activated for immune modulation, but definitely an area of research and where much work needs to be done. But again, the fact that we're less susceptible, we're not, we're really, it's a little bit like we joke sometimes, it's like a Vitamix in a sense that it's breaking up that tumor. But again, it's not denaturing the proteins and such. Just to give you a quick timeline, this is not a new technology. It's taken over 20 years to get to where we are today, through a lot of work, especially giving credit to University of Michigan, and really the incredible work leading up to that. And then I won't read through the whole slide, but I'll just highlight a few aspects. So we got our FDA Liver De Novo grant in 2023, started treating patients and giving Koji credit. They were the earliest adopter to take on this technology, and giving them a huge credit for taking that on. And then we've had, as you can see here, we now are in kidney. Our kidney trial should finish this month. We've treated 63 patients to date. And in our pancreas trial, which we're really excited about, we've treated 10 patients to date. Just a couple more slides just to kind of highlight the fact that, again, this can be in different rooms. It does not need to be in an IR or OR, although it tends to be as of now. But again, this is a technology that really can be integrated across a multidisciplinary platform, and again, also in outpatient settings. Just to give a highlight of how we think about where this technology can ultimately help patients. So first of all, as I talked about, and this will be, again, I'll leave this to our colleagues to get into more detail, but really, if you think about it, it can be used to enable curative intent, to help as a neoadjuvant to surgery, or as a bridge, or to sterilize vessels, or help with transplant. It can also, as mentioned, because we don't damage ducts and vessels, it can be used to treat centrally or treat across portal vein thrombus, for an example. And then also the exciting part is to combine it with immune therapy or checkpoint therapy. And then lastly, in the lower right-hand bucket, is really just because of the rapid destruction of the tumor cells, it's really an excellent way to palliate patients with tumors. And we have had really great examples of rapid relief of biliary obstruction, allowing patients to go back on therapy when historically they've had to have multiple stents placed to be able to get to that point. And just again, to highlight, it's a partnership. We're so thankful of the centers that we worked with. We're going to have about 100 centers coming on board by the end of this year. And we really give credit, as you'll hear from our both international and the US partners. Last couple slides just to highlight the 1,500 patients to date that we've treated across. This is really just within the US. There's more, as you'll hear, outside of the US. We have 52 centers now on board, over really close to 100 now trained. And then in the lower part of the slide here, you could see this is roughly the proportion of different tumors. So again, histotripsy is agnostic to really the tumor type, and the FDA indication is for tumors, liver tumors. So again, these are either metastatic or primary, but very exciting that we get that destruction despite the histology. Also, this just shows that this is a little bit outdated, but it shows that we could treat across multiple segments of the liver now. There's really no limitation. Now, it does require sometimes positioning the patient and/or using either jet ventilation or using double lumen intubation. But again, I'll let our colleagues get into that more. And then lastly, just a couple trials just to highlight that the FDA approval really was led by this, or was a resultant of this study. This was the Hope for Liver study, which was done both in the US as well as in Europe. And at a high level, this study showed that if you target the tumor appropriately, that 95% of the time you will destroy that tumor based on post-imaging within 36 hours. And the toxicity profile was very minimal. And also, we now know that, again, this is just showing you the breakdown of the different tumors within that study that led to the tumor indication agnostic to type. And then we just published this. This is our 1 year local control of the Hope for Liver study, showing a 90% local control just to show that it is durable. And then also the middle column here just highlights that the toxicity was very limited in that there was only one other device-related toxicity outside of 30 days, and that the survival is roughly, that the study wasn't set for survival really, but it's at least looks to be roughly equivalent to what you would see with other studies. In the commercial setting, this is just showing you a quick international study that was done. This was over across several centers. You can see the left-hand corner there, about 300 patients, 500 tumors. And what this really, the goal of this was just to see is what kind of toxicities or complications are we seeing within 30 days of treatment. And you can see here it's been very well tolerated. And our colleagues can get into some. A few things that have come up is that we notice that if you destroy a lot of tumor, sometimes you can get AKI or acute kidney injury, but that has resolved in almost all the cases. And then the death that you could see level advanced in major complications is really just progression of disease, not thought to be related to the device itself. We do not have NCCN guidelines yet, but we do have UNOS criteria. And I think, again, Koji will speak to this. And then lastly, just that we do have a prospective platform trial. Our goal is to enroll as many patients as possible on this study so we can continue to learn about this technology. And this will also provide great data and evidence to know where we should be comparing our technology to, whether it be surgery, radiation, or otherwise. So I'm really excited about this trial, a big investment from the company to do this trial, and will really teach us a lot over a very short period of time. So with that, I just want to say thank you for the opportunity, and I'll hand it back to my colleagues.